Okay, so now let's move on to the basic ECG interpretation. Okay, so we've broken it down into 8 steps to look at your 12-lead ECG rhythm strip, to have a systematic approach to say, okay, what am I looking at right now? And what is this information telling me? So we've broken it down into 8 steps. So step 1 is to determine the rhythm. To determine the heart's atrial and ventricular rhythms, we're going to use what's called the pen and paper method. So for atrial rhythm, we're going to measure the PP intervals, so the intervals between 2 consecutive P waves. These intervals should occur regularly with only small variations associated with respirations. Sometimes you'll see this, it's actually very common, it's called a sinus arrhythmia, where it'll be just slightly irregular. Okay, so the space in between PP intervals will be slightly irregular, but within normal limits, okay, if I can say it like that. And that's what's called a sinus arrhythmia. It just means it changes with your respirations. So when we measure our PP interval, we compare the two PP intervals with each other in several cycles. So consistently similar PP intervals indicates a regular atrial rhythm versus dissimilar PP intervals indicate irregular atrial rhythm. For the ventricular rhythm, we're going to do the same exact technique, except now we're going to do it between 2 consecutive R waves. In the QRS complexes, if an R wave isn't present, okay, use the Q wave of consecutive QRS complexes. The RR intervals should occur regularly, and they should be regular as well. It's also important to check for the presence of one P wave before each QRS complex. So in order to do the pen and paper method, place the ECG strip on a flat surface, then position the straight edge of a piece of paper along the strip's baseline. Move the paper up slightly so that the straight edge is near the peak of the R wave. With a pen, mark the paper at the R waves of 2 consecutive QRS complexes, and this will be your RR interval. Next, move the paper across the strip, aligning the 2 marks with succeeding RR intervals. If the distance for each RR interval is the same, the ventricular rhythm is said to be regular. If the distance varies, the rhythm is irregular. Use the same method to measure the distance between the P waves, the PP interval, and determine whether the atrial rhythm is regular or irregular. Okay. We then compare RR intervals in several cycles. As with atrial rhythms, consistently similar intervals means a regular rhythm. Dissimilar intervals point to an irregular rhythm. So the things we're going to ask ourselves in step 1 when determining the rhythm is is the rhythm regular? Yes, okay, great. If the rhythm is irregular, how irregular is the rhythm? Is it slightly irregular or markedly so? Does the irregularity occur in a pattern? So a regularly irregular pattern. And one thing, it's normal to have some variations of 0.04, which is one little tiny box. It's normal to have variations of one little tiny box. So is the rhythm regular? Is it irregular? Is it irregularly irregular or regularly irregular? So here's the pen and paper method. So what I'll do is I'll print out a 6-second strip, and I will print out a 6-second strip, and then I will print out another paper from the monitor. I will turn that paper around, and I will use my paper from the monitor to then go measure the consecutive R waves. So I'll do it exactly as the person's doing in this video right here. So they're doing it from R wave to R wave, and then they're doing it over multiple R waves to confirm that it's regular. Then you will do the same technique over the P waves. It's important to do both the R waves to see what the ventricles are doing, but also the P waves to see what the atria are doing. Okay, and you want to see too, is there some sort of communication between the atria and the ventricles? You could imagine that if, just thinking about it logically, that if you have one P wave for every QRS complex, well, you'll tend to know that, okay, the atria, the SA node is then communicating with the AV node, and that's just the standard baseline normal. But if there's no concordance between what's going on in the atria and the ventricles, well, then you can have what's called a heart block. Okay, you got some sort of blockage between the SA node and the AV node. And I'm saying the SA node and the AV node, they could also be ectopic, meaning it's coming somewhere else in the atria or from somewhere else in the ventricles. Okay, so that is the pen and paper method. So step 2 will be to determine the rate. There's several ways to determine the rate. The simplest is the 10 times method. Okay, so you are going to print a 6-second strip. And why it's easy to do a 6-second strip is because the ECG paper is marked in increments of 3 seconds. So you can see here, okay, which is 15 large boxes. Every tiny, tiny box is 0.04. So every large box, larger box here in dark pink is 0.2 seconds. So if you have 5 of those, you will have 2, 4, 6, 8, 10. You will have 1 second. So if you have 3 times 5, 15 boxes will give you your 3 seconds. So if you have 30 large boxes, that's your 6 seconds. Okay, you need your 6-second strip. So print out a 6-second strip, and then you can count the number of QRS complexes, for example, in that 6-second strip. And just like when we were calculating our heart rate in 10 seconds, or our pulse in 10 seconds, we're multiplying by 6. Well, now it's easier. You have a 6-second strip, you just multiply by 10. So if I had, for example, 6 QRS complexes, or 6 waveforms, I should say, I multiply that by 10, that gives me a rate of 60. So you can calculate both the ventricular rate and the atrial rate. Okay, so if you want, count the number of R waves times it by 10. You can count the number of P waves and count it by 10. And sometimes, depending on the rhythm, you can have different atrial and ventricular rates. Okay, so it's important to actually calculate both rates, not just the QRS complex like I was saying before. You should most likely do it with the P waves and then the R waves. Then you're going to ask yourself, is the rate fast, so over 100? Is it slow, under 60, or within normal limits, between 60 and 100? Okay, so you want to know if you're bradycardic, tachycardic, or within normal limits, eucardic. Step 3, we're going to evaluate the P wave. Okay, so start with the P wave. We're going to say, are the P waves present? Okay, because they may not be present. Somebody who has atrial fibrillation will not have a P wave. Do they have normal configurations, meaning do they have a smooth contour? They're nice and rounded out. Do they have similar size and shape? If they have different sizes, they may be coming from different parts of the atria, okay? Not necessarily from the SA node. The signal coming from the SA node will have the same shape and size. Is there one P wave for every QRS complex? Okay, so there's a lot of different reasons why you can have a abnormal P wave. We can have atrial enlargement, which you'll have a nice large P wave. You can have atrial fibrillation, where you'll just have fibrillatory waves, so you will have no discernible P waves. You can have something called atrial flutter. It actually looks like a sawtooth. The P wave will look like a sawtooth. You can have some premature atrial contractions, so you'll see they'll have this random P wave followed by QRS complex, but your rhythm was mostly regular, and then you have this one random beat that came out of nowhere. And your P wave looks different. Well, that could just be a premature atrial contraction. It just from maybe some sort of stimulus that caused a premature beat. You can have things like lung disease, which will cause changes in the P wave. I think I mentioned in class at one point P pulmonale. So just having a lot more work of the right side of the heart can lead to changes also in cardiac electrical physiology. Step 4 is determine the duration of the PR interval. So to measure the PR interval, count the small squares between the start of the P wave and the start of the QRS complex, and then multiply the number of squares by 0.04 because each square is 0.04 seconds. We're going to ask ourselves, is the PR interval a normal 0.12? So about 3 boxes to 0.2, okay, 5 boxes. So it should be 3 to 5 boxes for your PR interval. Is the PR interval constant? Okay, is it always 0.2, 0.12, 0.12, 0.12, or is it changing? Okay, there's different types of heart blocks where you can have an increasing PR interval or you can have other PR intervals that are just delayed, which they're prolonged, which would be something in your first degree heart block. Then you can have things like a second degree heart block where you can get longer and longer and longer until it just drops a beat. Okay, these are all things that you're going to learn more in Med-Emerge. But again, now we're just looking at what are the steps and what are the criteria that we're looking at. Cause of abnormal PR intervals, heart blocks, AV node disease, medications such as beta blockers, calcium channel blockers, hyperkalemia, high levels of potassium in the blood, acute rheumatic fever, Lyme disease, myocarditis, inflammation of the heart muscles, congenital heart defects. Step 5 is determine the duration of the QRS complex. When determining QRS duration, be sure to measure straight across from the end of the PR interval to the end of the S wave, not just to the peak. Remember, the QRS has no horizontal components. So to calculate duration, count the number of small squares between the beginning and end of the QRS complex and multiply this number by 0.04. The normal QRS complex will typically be less than 0.12. Okay, normal duration would be 0.06 to 0.1. Okay, 0.12. Are all QRS complexes the same size and shape? If not, measure each one and describe it individually. Does a QRS complex appear after every P wave? These are the things that you have to ask yourself. So causes of abnormal QRS complexes, a bundle branch block, right or left. Okay, because you can have a right bundle branch block, you can have a left bundle branch block. Ventricular hypertrophy, myocardial infarction, electrolyte abnormalities, hyperkalemia, hypocalcemia, Wolff-Parkinson-White syndrome, medications such as sodium channel blockers, cardiomyopathy, ventricular rhythms, whether ventricular tachycardia, ventricular fibrillation. Step 6, evaluate the T wave. So you're going to ask yourself when you're looking at the T wave, are they present? Do they have a normal shape? Do they have a normal amplitude? Do they all have the same amplitude? Does the T wave have the same deflection as the QRS complexes? Cause of T wave abnormalities include myocardial ischemia, myocardial infarction, electrolyte abnormalities. So hyperkalemia, hypokalemia. Typically in hyperkalemia, we'll have a large peaked T wave, whereas in hypokalemia, we'll have a flattened out T wave. Drug toxicity, for example, digitalis toxicity, pulmonary embolism, central nervous system events, for example, a stroke, hyperventilation, and cardiomyopathy. So next in step 7, you'll determine the duration of the QT interval. So we'll count the number of small squares between the beginning of the QRS complex and the end of the T wave, where the T wave returns to the baseline. So multiply this number by 0.04, and then ask yourself, is the duration a normal 0.36 to 0.44 seconds? Causes of abnormal QT interval, we can have a congenital long QT syndrome, medications such as antiarrhythmics, antibiotics, antipsychotics, electrolyte abnormalities, hypocalcemia, hypokalemia, myocardial ischemia or infarction, cerebral events such as a subarachnoid hemorrhage or a stroke, Brugada syndrome, which is a rare but serious condition that affects the way electrical signals pass through the heart, our cardiomyopathy again, and our hypothermia. The last step is step 8, is evaluate the other components of the ECG. So we're just going to look at ectopic beats and other abnormalities. We'll check the ST segment for abnormalities and look for the presence of a U wave, which we can sometimes see in things such as hypothermia. But U wave is just an extra wave after the T wave. We're going to note our findings and then interpret them by naming the rhythm strip according to one of these findings. So the origin of the rhythm. So if it's coming from the sinus node, the atria, the AV node, or the ventricles, well, then we're going to name the rhythm according to that. So it could be a sinus rhythm or a ventricular rhythm or an atrial rhythm, okay? We're going to then go according to the characteristics, bradycardia or tachycardia. And then we're going to go to the abnormalities, for example, flutter, fibrillation, heart block, or other arrhythmias. So for example, we might say something like, if we have a normal P QRS complex T wave, okay, it's evident that it's coming from the SA node. Well, we know it's a sinus rhythm, okay? If it's everything is within normal limits, then we'll call it a normal sinus rhythm. If it's fast, well, we might call it a sinus tachycardia. If it's slow, we'll call it a sinus bradycardia. If we see that we have fibrillatory waves instead of a P wave, well, we might call that atrial fibrillation. Or if we have a flutter wave, we'll call it atrial flutter. If it's going fast, and you can see that the rhythm is, the QRS complex is very wide, so you can tell it's coming from lower down, well, then you might call it a ventricular tachycardia. Okay, one of the things that we tend to shock in pulseless ventricular tachycardia. Again, this will all make more and more sense the more you go through your education here. And then, like I said, in next courses with more advanced 12-lead ECG interpretation, where you'll look at all the different types of arrhythmias and know how to find them or name them. But for right now, the most important part, specifically too with our ACS patients, is being able to identify this one rhythm right now, which is STEMI, okay, standing for ST elevation myocardial infarction. What we're going to be looking for is 1 millimeter or more in 2 or more contiguous leads of elevation, okay? If it's in leads V1 and V2, we're going to be looking for at least 2 millimeters or more of elevation. So here we have our P wave, our PR segment, our PR interval, our QS complex, our QT interval. But here you can see we're not coming back down to our isoelectric line. We have elevation of the ST segment. The point where it turns up is actually called the J point. So right here, if I look at the normal morphology, we'll call this the J point, the point where if we go from our PQRS and then going to the T wave, that will be our J point. If we have elevation of more than 1 to 2 millimeters from our J point, then we can diagnose that as an ST elevation. You can actually see here what we'll tend to see in the progression of an MI, starting from normal morphology. Then we'll have what's called an hyperacute T wave. So we'll have a Y tall T wave. That could be one of the first signs of an MI, which will tend to progress then to an ST elevation. We can further on when it's post elevation, or further on into your infarction, we'll have a deepening Q wave. And actually this Q wave can persist. If you have an ECG and you have a patient who says they've never had a heart attack before, but you have a deep Q wave, you can determine that they potentially could have had an MI in the past. So here's a 12-lead ECG that clearly shows a STEMI. So if you look at lead 1 here, if you look at the isoelectric line, you can see that there's a depression of the ST segment. Okay. In lead 2, you have a clear elevation of the ST segment. Lead 3, a clear elevation of the ST segment. AVL, you have a depression of the ST segment. AVF, you have a elevation of the ST segment. And in the other leads, such as V2, V3, you have some ST depression as well. If we look at the interpretation of the ECG here, you can see the heart rate is at 47. It has some information related to the PR interval. It's saying 0. I'm not sure why it's saying 0. I think it's because it's not picking up on certain P waves. As you can see clearly P wave here in lead 2 and 3. But you're not seeing a clear P wave in a lead 1. But what's important is you can actually see they write possible inferior epicardial injury, marked ST depression consistent with subendocardial injury, and then here, ****, acute MI, suspected, ****. It'll say unconfirmed, but again, it's because it's a monitor, it's a machine, it's not confirmed by a physician. Okay, so don't worry if it says unconfirmed, you're still treating this patient as if they are having a heart attack, okay? But you can clearly see here I have elevation 2, 3, and AVF, which is an inferior wall STEMI. So here are the different areas of the heart. Just a quick review here. You have the coronary arteries of the heart. You have the right coronary artery, you have the left coronary artery, you have a circumflex branch, and obviously they have more and more divisions coming off of those major coronary arteries. Now, if we look at the 12-lead ECG again, here it's been color-coded in terms of the different areas of the heart. We have the lateral here in yellow. So we have leads 1, AVL, V5, and V6. And then we have inferior in green, 2, 3, and AVF. So that's just the MR that we just had here, 2, 3, AVF. So that's our inferior leads. We have in red, we have AVR and V1. And then in blue, we have V2, V3, and V4. So when we talk about 2 or more contiguous leads, this is what we're talking about. Contiguous meaning next to each other in terms of anatomically speaking in the heart. So if we had 2 leads in green, or 2 leads in red, or 2 leads in yellow, or 2 leads in blue, that's what we need for diagnostics of a STEMI. 2 or more contiguous leads with 1 to 2 millimeters of elevation. So if we have elevation in the lateral leads, we'll say it's a lateral wall MI. Oftentimes we'll see it with the anterior lead wall, so we'll call it an anterolateral MI. And then this one is one of the most common ones that we'll see. It's an inferior wall MI, or at least it'll be the easiest to see according to the 12-lead placement that we place our patients on. So one of the things that I use to memorize the different areas that I'm seeing on the ECG strip is I do Li, Li, Sa'al, okay? So Li, there's 2 eyes, okay? So there's inferior. Then I go Li, because there's only 1 eye. I'm skipping AVR. Then septal for our V1, V2. And anterior, V3, V4. And then lateral. So when I'm looking at it, again, you may have a better way, but I would just always remember Li, Li, Sa'al, okay? Then I can quickly determine which parts of the heart are affected, or which parts of the heart correspond to which leads on my ECG. But at this point of the game, again, most important thing you need to do is to at least read the interpretation on the ECG. And if you see infarctus aigu or acute MI with your star, okay, run it as a STEMI. And then once you develop the skills to actually interpret an ECG, well, then you can also confirm with your own clinical diagnosis. So we'll have a practice session this week during lab. We'll actually practice doing 12-lead ECGs. We'll practice reading the ECG as well, or at least following the steps. We'll do both the standard electrode placement and the NEP electrode placement. And please let me know if you have any questions. Don't hesitate to send me an MIO. So again, here it's extremely important to be able to understand how to acquire and perform a 12-lead ECG so that we have a nice rhythm that we can use to interpret and diagnose. It's important to have a proper technique in terms of proper lead placement and having alternatives to our standard electrode placement should our first standard electrode placement not give us a diagnostic ECG. It's important to be able to troubleshoot when we have artifact, okay, which is very common. And it's important now that we're going to get a little bit of practice in class, but don't worry, you're going to get ample opportunity to on stage and during your preceptorship to do ECGs on different body types, different age groups. And again, if you have any questions, don't hesitate to reach out to me. For homework, there's videos that I've posted in Google Classroom. They talk about basic ECG leads. There's 3 of them. Watch them. Read all of the 12-lead ECG documents. We have the NEP, the Tech 11 protocol. We have a clinical bulletin. Read the M1 protocol and Med 3 protocol. I'm actually going to do a separate 3rd-part video to go through those with you. They're very quick, very easy. Read the policy on performing 12-lead ECGs on female students. And then, of course, following lab, be sure to perform and practice chest pain scenarios and get your 12-lead ECGs, and then practice doing your 12-lead ECGs.